Hi, this is Amanda Dolan, and welcome to the Mental Society. Today, I am joined by Dr. Rebecca Allen, and Dr. Allen has authored papers and researched everything from sleep and memory consolidation, as well as the quality of life for individuals with multiple sclerosis, or MS. She's authored a chapter on sleep and sleep disorders for the Harvard textbook, Neuropsychiatry and Behavioral Neurology, Principles and Practice. It was published in 2020. And her main clinical interest is neuropsychiatry and lots of the cognitive behavioral manifestations of neurodegenerative diseases, dementia, MS, epilepsy, stroke, brain tumors, and 5 million other things. And one of the things you really specialize in is ECT, or electroconvulsive therapy, which many people would call electroshock therapy, probably would be what many people think of, but that is not what it is.
Hopefully not. In animal studies, it's electroshock. In humans, it's electroconvulsive therapy.
And so, like, if we're talking about, like, you know, I kind of mentioned to you that I had spoken with my psychiatrist about ECT, and when I think of it, I think of what, you know, the videos that I saw from the 50s and 60s, even all the way, you know, to like One Flew Over the Cuckoo's Nest, right? And that having to be held down and a full body, you know, tensing up of all the muscles. We hear that, like, you know, bones are broken and shoulders dislocated, but I don't think that's what it's like anymore.
Not for a really long time, but just addressing One Flew Over the Cuckoo's Nest, you know, head on. I actually love that movie. I think it's like a really great, beautiful piece of drama. I love the play. One thing that's problematic in terms of people taking away anything from it, you know, about psychiatry in general, is that they did the ECT and the frontal lobotomy really close together time-wise in the movie. And so when you're thinking back, you saw it 5 or 10 years ago, it's really easy to equate the two, but they're not even remotely similar. And you certainly wouldn't get anything like a lobotomy anymore, not for a really long time. And it never worked anyway, right? So the ECT, though, given that reputation, given the Scientologists, which have a lot of these sort of anti-ECT websites where they show the leather straps, and they are very anti-psychiatry as a religion, and a very large religion at this point, and they have a lot of advocacy in that regard. ECT, we wouldn't do it at all if it didn't work really, really well, right? It is hard to do it. It is hard to provide ECT, and we do it because it works for no other reason, right? So ECT, electroconvulsive therapy, has been around for a really long time. And despite what people say or what you hear, it's worked that whole time. Not in everyone, not all the time, but ECT did work. It was efficacious. Sylvia Plath, when she wrote her book about her experience as a mental health patient, she got ECT and it actually worked. And then when she committed suicide, she hadn't had it, right? So the reputation is not very well deserved in terms of efficacy or in terms of social control so much. Doesn't work for that, by the way. The reputation with the whole body clenching, with physical risk, broken bones, that was actually the case at one time, certainly, 100%. So there was a time in ECT's history when people needed x-rays right after treatment in order to make sure that there was no physical injury. That hasn't been the case pretty much since the advent of anesthesia and the use of anesthesia for ECT. So electroconvulsive therapy now, and for decades at this point, has been done under full anesthesia, where a person is given a medication to put them to sleep, the same medications that we use for anything else, you know, in an operating room to go to sleep for a procedure, and then a second medication to make their muscles relaxed so that they do not shake. So ideally, ECT is extremely undramatic to watch, kind of boring. So a person it rolls into the room after having checked in with the nursing staff, not eaten for 8 hours, not drank anything for 2 hours. They get the IV put in their arm and have a liquid drip like you normally would do for anybody that, is coming in dehydrated, right? And they are connected to all of the normal monitoring equipment that any anesthesiologist uses for any procedure. So a blood pressure cuff, the stickers on the chest that measure the heart rhythms, and a thing on the finger that measures oxygen level in the blood. In addition, for ECT, we put 2 stickers, the same as the ones we use for the heart. We put 2 stickers on the forehead and behind the ear, and then on the clavicle, on the collarbone. And that is how we get a printout of the brain's experience of the seizure, the brain waves from one set of these stickers gives us the brain waves from the right hemisphere. The other set of these stickers gives us the brain waves from the left hemisphere, and that's called EEG, electroencephalogram. So when a person comes into the treatment room, there's 2 doctors in the room, an anesthesiologist and a psychiatrist, and then there's a nurse. And then in my program, and many programs actually, there might be somebody learning. So a new doctor who is a few years out of medical school, but not independent yet. Then in my program, a person is in the treatment room for about 20 minutes total. The first 6-7 minutes of that is conversation. First treatment, do you have any questions? I'm going to show you the bite block that we use to protect your teeth. I'm going to show you the leads that we use to send the stimulus into your brain. Do you have any questions? That kind of thing. For subsequent treatments, second treatment, third treatment, fourth, we're asking, how did the last treatment go? Did you have any issues, any side effects? If they say had a headache or they had nausea, we can add medications at that treatment in order to help address those things so they don't get it again. Then when we are finished with the conversation, the anesthesiologist gives the sleeping medicine through the IV. And the sleeping medicine, its main side effect later can be nausea. Most people don't get nausea. If they do, we treat it, right? And then the muscle relaxant, which is usually succinylcholine, and that can have as a side effect feeling sore later, because succinylcholine, it is going through and actively relaxing all of your muscles, and that can make you feel sore. Interestingly, at treatment 2 or 3 or 4, you don't feel sore anymore because your body gets used to that drug, and it doesn't have the same side effect with that. So after the sleeping medicine and the muscle relaxant are in, then the psychiatrist goes to the patient's head, puts the settings into the machine, holds the leads on the head, and pushes the button. And we control how we start the seizure, the therapeutic seizure. We control how we send the electricity in, like where, whether we send it in with right unilateral lead placement, so only putting the leads on the right side, or by temporal lead placement, where we have one lead on each side of the forehead. And we control the dose, like how long is the stimulus delivered? 8 seconds is the longest. How much? The highest dose we use for ECT, 576 millicoulombs, would light a 60-watt light bulb for 0.01 seconds. So
that's that's not nearly as much electricity as I imagined that.
Sorry, 0.1 seconds, not 0.01. Yeah, I misspoke.
But still, 0.1 seconds, that's nothing, right?
And that was a pretty interesting paper where somebody calculated that out. So very, very little, and that's all it takes. And when we start, we send the stimulus, the tiny bit of electricity into the brain, and then the brain does its thing. The brain has the seizure, and we're watching the patient, obviously, and we're also watching the output from the ECT machine, which is the brain waves. And we're looking for a pattern of brain waves, looking like this at the beginning and like this in the middle and like this toward the end. And we want a pretty sudden stop. And we joke that it is the only time in medicine you ever want
a flatline.
Right? But at the end of an ECT treatment, that sudden stop and the the post-seizure suppression, post-ictal suppression, it's called, where you get a surge of the molecules in your brain that are sort of the calming down side of things. So GABA is what it's called. That is really associated with the outcome, with response to ECT. So, and then the person is only asleep, fully asleep for about 10 minutes. And they start to wake up, move around on their own, breathe on their own. When you're under full anesthesia, the anesthesiologist is breathing for you with bag masking usually, because it's such a short procedure, but they have all the stuff there to intubate if they need to. They like almost never need to. And so a person doesn't remember waking up in the treatment room, but they remember waking up in the recovery area where they're monitored, you know, with a nurse that's just theirs. So 1-to-1 and in recovery area for about 20 minutes. And then they go home. So that is sort of the beginning to end experience. If everything is running on time, that takes about 90 minutes. I tell people to expect 2 hours from walking in to walking out. And that's it. And it looks very not exciting, actually.
And it's not a like one and done then, right? Like it's multiple.
It is a course. Exactly. Yeah. So if a person is in a really bad depression, which is when we do this, we don't do ECT if somebody has a history of depression and is trying to, you know, cure it. It's not a cure. It's a treatment for an active, bad episode of depression. We expect a person is going to need 12 to 15 treatments. You see all over the internet, 8 to 12 treatments. That's everywhere on the internet. That is old information. When ECT programs used to mostly do the higher dose, stronger version of ECT, where which is called bitemporal, where you put one lead on each side of the head, that results in shorter treatment courses because it's a stronger treatment, but it also has more thinking and memory side effects, which we can absolutely talk about. Then the right unilateral lead placement, which is newer, where you put both leads on the right side of the brain, and then the seizure spreads from right to left. But because you are only stimulating on the right side gets more of the treatment. And the right side of your brain is more involved in visuospatial processing. The left side of your brain is more involved in some of the working memory, explicit memory, like meaning events and language. So people notice cognitive side effects from the left more than they notice cognitive side effects from the right. So when stimulating on the right, we are making the experience, you know, more tolerable, easier. If a person doesn't respond to right unilateral, like we do 6 treatments and there's just no movement, no benefit, we start talking about, do you want to switch to the stronger version? Do you want to turn up the dose and stay with right unilateral, or do you want to switch to the stronger bitemporal version? Anything we do to make ECT stronger has a higher chance of side effects. So we start with a less strong version and work our way up from there if we need to.
I think that's the way, right? Most medications or treatments.
Exactly.
Or I mean, most doctors, right, want to start as little as possible and work up.
And some, you know, and it's about personal choice too. We have some people who are maybe coming from out of state or who are so ill that right unilateral isn't worth the risk of, you know, what if it doesn't work? And we've wasted 2 weeks, right? So we have some people who are so ill that we say we really think you should start with bitemporal. And we have some people who choose to because they want to have fewer treatments and they want to get it done, right? Yeah.
And so, you know, I know like for me with my bipolar, it took a while to get on the right medication and become pretty stable. But this is often like when medications are not doing the whole job that needs to be done, because medication is the first, like that's typically the first course of action. Or
unless it's like an emergency, yes. But realistically, even if it's a situation where ECT should be the thing you go to, maybe second or third, it tends to be something that people do much farther down the line, even in acute situations, just because the access to ECT is so poor. There aren't enough programs. The programs that exist aren't big enough. So accessing ECT is actually difficult in our current.
And I think that's true for mental health care, period. Seen some studies that say, like, I think we're at 37% of the needed practitioners to fully meet the mental health needs of our country, which makes me a little angry as someone with like mental health things. It's like well, first you said like 12 to 15 treatments. So how quickly do those come back to back? Is that every day?
Two or three times a week, and 2 times a week is a little bit more European because they have better work-leave policies and better public transportation. So people can afford to do ECT for more weeks, and 2 times a week is a little gentler, fewer, less risk of side effects. 3 times a week is more American and what most Americans choose to do because it's a shorter course overall, but there are more cognitive side effects when you're doing the treatments close, more of them close together. If you are doing ECT less than twice a week, we wouldn't consider that an intensive course where we're trying to get you better. We would consider that trying to prevent you from relapsing. So that would
more
be
of a maintenance or a
taper and maintenance after an intensive course is once a week or less.
So that one you said, like, the more American is the 3 times. So how much time is needed off of work when you're getting this treatment?
And that brings us right to the cognitive side effects, because the answer there is it depends on what you do for work. So ECT during an intensive course, you have cognitive side effects that are worsening over the course of treatment. Okay. So you have more cognitive side effects after treatment 5 or treatment 8 or treatment 12 than you did after treatment 2 or 3. And this varies a lot. I see patients who have had 12, 13 treatments and they say, "You overwarned me, Dr. Allen. I don't have any cognitive side effects. I'm fine." I have other people who have more cognitive side effects than they expected and are really bothered, disturbed by it. When a person is getting ECT, that is when the cognitive side effects are the worst. And most domains of cognition, things that we can test with pencil and paper tests or with computer thinking and memory tests, do actually go down with ECT. So it isn't just short-term memory, it's also your visuospatial function, meaning if you're a gamer, your ability to navigate in a virtual world, or your ability to do puzzles. It also affects your ability to drive. So there is a driving restriction with ECT. The rule in our program, and I think this is a pretty common rule, any week that you have more than 1 ECT treatment, you cannot drive that entire week. So we expect people will go 4 to 6 weeks with no driving whatsoever. Also processing speed, which of course affects driving too. And then what people notice the most is difficulty with remembering recent things, remembering things that they did in the past few days, the past few weeks, remembering what they're supposed to do tomorrow. And then there can be difficulty retrieving some older memories. That tends to come back. People do not tend to lose old memories. And if they do, there's usually something else going on besides just ECT. So history of drug or alcohol abuse, history of dissociation, meaning feeling outside of yourself, separate from yourself, periods where you feel like you can't remember what happened. History of trauma, either mental, terrible things that happen to you, or physical head trauma. Those are all risk factors for having cognitive side effects that are beyond the average, the norm. So we expect that all of these cognitive side effects, everything we can measure with a pencil and paper test or with a computer test, gets back to the person's normal before ECT, or even better than normal, because depression is not great for your cognition either.
It's not.
Frankly. By a few weeks to a few months after the ECT course. And there's lots of studies out there on this. So many studies with formal cognitive testing before and after ECT that all show the same thing. 6 months after ECT is where a lot of these studies did their like retesting. So we have tons of data that says by 6 months, people are either as good as or better than where they started. What you might lose that is permanent is some memories from recent months before the ECT course. So if you get ECT in January, you might forget Christmas, Thanksgiving, Halloween, right? You might forget things that you would normally trust yourself to remember. Our brains are forgetting most of the things most of the time, right? It's much easier to remember what you had for breakfast this morning than last Friday. For a reason, there isn't space, you don't need it. During ECT, the hippocampus, the part of the brain that actually is taking sort of temporary memories and processing and moving it into long-term storage, that is rough enough that a neuroscientist would say it's inaccurate, but close enough for this purpose of explaining the hippocampus's significance. The hippocampus is reforming a little bit. It's growing new cells during ECT and new connections. And probably while that is happening, it's not doing its job as well. That's one sort of theory or explanation for what's going on. But during the ECT course, you're not forming new memories as well as you usually would. And things that are recent, that are sort of loosely held, are more likely to be lost, gone. Where people find this the most disturbing is if they went on a weekend trip or a vacation within the 3, 4, 6 months before ECT and they forget it. Or if they were told something about someone else that should be significant, and then they forget that they heard that information. You're much more likely to forget things that you were told or heard about than to forget things that happened to you. And you're more likely to forget things that are recent than things that are farther back.
And would you consider this a life-saving, like, medical treatment?
100%. Oh my gosh, 100%. So the bread and butter in my practice is severe treatment-resistant depression, or bipolar depression, where people have tried a lot of different things, and maybe they've gotten better at some point, but they're not better when we see them, really.
Right.
And you have to always weigh the benefits of something against the downsides. And there are downsides to ECT. I mean, absolutely. I don't think there should be sugarcoating of that. I think it's very exaggerated in a lot of the things that you see.
Right, it sounds like it.
Or grossly inaccurate. But you have to be able to weigh what is the worst thing that could happen with ECT in terms of my cognition, memory, side effects, with what if I die from suicide? Which is the case for many people we are treating with ECT.
Right.
Also, even if they're not feeling like they want to, do something to make themselves die, there is a level of suffering that is intolerable, where you're so bad you can't function in your family, you can't work, you're not enjoying anything, your self-care might be impaired. Some people that we treat are in the hospital when we're treating them. They're admitted to an inpatient psychiatric unit. There are also people who have conditions other than depression who need ECT. Catatonia is one of them. And I think if you're looking at, this is now an old reference, but if you're looking at pop culture representation of catatonia, they did a decent job in the Robin Williams movie Awakenings.
Oh, when they give the medicine and then they can catch the ball, or the music, was it the music that comes on and it's been a long time.
Yeah, and so catatonia isn't, I would think less about the sort of how they responded to the drug in that movie and more how they looked at the beginning. And that is what catatonia very often looks like. A person is just either, if they're inappropriately responsive, like repeating back to you what you just said to them, or repeating the same thing over and over, or just really not responsive at all. And they might have muscles that are stiff and in certain positions, waxy flexibility is the sort of technical description. Or they might have something called the pillow sign, where if you pull a pillow out from under their head when they're lying down, the head stays up. Just these very abnormal physical and mental clusters of symptoms that go together that respond really well either to high dose benzodiazepines, which usually is what's tried first. That's like Ativan, right? Klonopin, that's benzodiazepines, or ECT, which works 90% of the time. I mean, really, really successful treatment for catatonia. We also have people coming in for hearing voices for schizophrenia. That's much rarer in the US than it is in like say third world countries where there's very little ECT. The ECT programs they have will be pretty much all people with schizophrenia, because that's the mental illness that nobody can ignore, right? People can ignore depression. They shouldn't, but they can, right? In our country, ECT is more common for mood disorders than for psychosis.
I think about is, so like, I'm thinking about like for myself as an individual with bipolar 2. So, and you talked about like that, you know, not being able to take care of yourself. And I still think of the time when I couldn't get out of bed well for so long that I actually had to go to my hairstylist and have her brush out the knot of hair in the back of my head because I hadn't washed my hair, I hadn't showered, and you know, it's so in that kind of case, I wasn't on medication, but if I was on medication and that was where I was at, that's still not able to get out of bed, not being able to interact with my family in any meaningful way, that's when like ECT might come in.
Yeah, and also the other end of bipolar disorder, which with bipolar 2, you probably didn't have as bad a manifestation of this as people do with bipolar 1. But I have had patients who get into a manic episode, and with mania, unlike with depression, insight tends to be more impaired. People don't necessarily recognize that they're in a manic episode or that anything is wrong. So they will sometimes stop their medications. So in that case, getting them back on medication, you would try, you might not succeed. If they end up being hospitalized, you would think about ECT.
Okay.
Yeah.
And that's
ECT works for mania too.
Yeah. Oh, I was not aware of that. So that's interesting bit of information. But I think that was something you mentioned was when people start to feel better, sometimes they stop their medication. Yeah. So can we just like have a moment of don't stop your medication without talking to your doctor first?
Yes. And I will say the rule of thumb is if you have an episode of depression, that's your first ever episode of depression, like you were fine, no mental health problems, and you get depressed, it lasts a few months, you get on a medication, you get better, you should stay on that medication for at least a year. Some people will say 2 years. The least I've heard in terms of an official recommendation, consensus, data-based kind of agreement is a year.
Okay.
If you have had repeated episodes of depression, or if the episode you had was so bad that you were feeling like you wanted to do something to end your life, or you ended up in the hospital, the recommendation for how long to stay on meds is even longer than that, perhaps even in your entire life. The kind of people that I see are either people who are generally not seeking ECT, but seeking transcranial magnetic stimulation or seeking ketamine treatment, which we can talk about, but who are like against medication or have had side effects to a lot of medications, and so they want to try something that's different. Or with ECT, it tends to be people that are very aware that they have a chronic mental illness, are not the kind of person that would suddenly stop their meds usually. And ECT is the next thing to try because it's so bad.
Yeah. And, you know, I just want to one more time, like psychotropic meds, when you get off them, it's important to talk to your doctor because you got a taper. You might have serious side effects of getting off that medicine. I always think that's important because stopping a medication like that can be really dangerous.
Well, it depends on the medicine. Yeah, right. I would say that for standard antidepressants, there has been some highly publicized information about withdrawal that is very, very much exaggerated and not consistent at all
with
a
clinical.
experienced psychiatrist, what we observe in practice. The impetus for doing that, for saying antidepressants do harm, antidepressants lead to withdrawal, is coming from a place of people being very concerned that antidepressants are being overused. That's the generous, positive way of looking at it. The other way of looking at it is that there's a huge stigma in mental health. This idea that you shouldn't have to have a medication to help you not be depressed, that depression is an indulgence in feeling sad. And if you did the right things, you could just not be depressed.
Right.
And that is also why we have a shortage of mental health providers, psychiatrists, therapists, mid-level providers like physician assistants, nurse practitioners. There's a shortage across the board because mental health is very undervalued. It's very under-reimbursed. So
well, yes, that, and I think, you talked about well, let me share a story. I go to church. I went to a different church than my normal one to go with a friend, and someone came up to me and I was telling a little bit about my story, because part of my, when I was suicidal, I was laying in bed and I heard a voice, and not in a psychotic voice way, but it said, "I'm not done with you yet." That was the only voice I heard. And then I went and found treatment. And so I was sharing this with someone and they were like, "Oh, well, if you just prayed more and you asked God to heal you, you could get off of your medication. And that's what God wants from you, is to not be on medication." And my response,
there are entire religions that believe that, the Christian Scientists and the Scientologists.
Well, and my response to that person was, I believe that God gave the scientists and the doctors the knowledge and the tools and the resources to create these medications that save my life. So that's how I choose to look at it. That may not work for everyone, but
do you think that, we can talk about that too, but do you think that she would have said the same thing if you'd said you'd had skin cancer?
I'm sure there would have been, well, we need to pray, but make sure you take your treatment. We'll pray that the doctors provide the right treatment, the most efficient treatment.
Would have been different. This is the stigma. This is giving people the benefit of the doubt. I think it's coming from a place of people want to believe that they have control. They have control over their identity. They have control over their brain. They have control over who they are. They have control over their emotions. And the existence of mental illness is very threatening to that notion. If somebody can become very depressed and it's not because something happened to them or because they did something or because they're not doing something, that's a really, really scary idea.
But the reality is that roughly 20% of people experience some mental illness in their life, and 5% have a serious mental illness that long lasting.
It's very common. Right?
And so that's more than, diabetes, probably. I mean, I don't have numbers for that, but type 1 diabetes, which, is.
I don't have numbers for that either.
I don't know. I'm wondering, or,
mental illness is so common, and it's not a new problem or a modern problem or a modern day indulgence. Mental illness has been around forever.
Yeah. It's funny, when I was doing my research on ECT, I found that Benjamin Franklin wrote that an electrostatic machine cured a woman of hysterical fits. So if Benjamin Franklin, literally centuries ago saw benefits of this, right? I mean, of course, hysteria in women, there's a whole
it's a name that got slapped on a lot of things that we would nowadays still call mental illness for the most part, but we would call it something else.
Right. So I want to take a minute with the TMS, which is transcranial magnetic stimulation. Did I get that right? Okay.
Yes, you did. Yeah.
And I have a good friend that this was probably 2 or 3 years ago now. And I think it was fairly new when she was having it. And I know that for her insurance didn't cover it at the time. Don't know if it would now, but she thinks, I mean, I know she went for a number of treatments and then she goes back kind of for a tune-up or a,
Sure.
but she says that she feels like it almost cured her. I know that she's not on medication right now with it. So, and I know that that's one of your, that's one of your things.
Yes.
So how is that different than from ECT? Because I guess one's magnetic, one's electric, but
the easy answer to that is everything is different. The only thing they have in common is that they're stimulating the brain in an attempt to treat similar conditions like depression. Everything else is different. With ECT, in severe treatment-resistant depression, it works in about 8 out of 10 people. And by works, I mean it has a really significant positive effect. Mm-hmm. And of those 8, half of them, the depression is gone. The other half, the depression is really, really much better. But 8 out of 10 for ECT, right? That's why we do it. For TMS, for depression, it's closer to 6 out of 10. And what I like to tell patients is that TMS is not one thing. TMS is a tool. So transcranial magnetic stimulation is a tool. You can use it for research, and you can use it for many different clinical applications, depending upon what coil you're using, where you put it on the brain, how you send the pulses through the coil. So it's a tool. And when you say TMS works for this or doesn't work for that, it's like saying, well, drugs work for this or drugs don't work for that. And you got to ask, well, which drug are you talking about, right? So it's the same idea with TMS. Which protocol are you talking about? So for just overview, TMS is pulsing electricity through coils, tightly wound circles, coils of wire. And when the electricity is pulsed through the coil, that creates a magnetic field perpendicular to the electrical current. And that's Faraday's law. There's this relationship between electricity and magnetism, and that's what TMS is doing. The most common type of coil looks like a number 8. So we call it a figure of 8 coil, where there's 2 circles of wires that overlap in the middle. And so we send the electricity into the coils in pulses. And because the electricity has to be fluctuating to create that magnetic field, right? So when we treat depression, we put a coil over the left dorsolateral prefrontal cortex, which is a fancy way of saying the left side, kind of top of the forehead, right? The measurement of it's a little more precise, but that's approximately what we're talking about, which is a frontal executive function part of the brain. And we are sending the pulses through the coil quickly, generally 3,000 in a session at a rate of 10 per second, 10 hertz. And there are different protocols with one kind of coil. Right. The rate is actually 18 hertz. With the figure of 8, the rate is usually 10 hertz. There are some papers out there that have published 5 hertz. So just acknowledging there's variability, this is like the standard, most commonly used protocol. And we send the pulses in these trains with pauses. So a bunch of pulses in a row, pause, bunch of pulses in a row, pause. The whole treatment lasts about 18 minutes. Okay. We schedule generally for half an hour for, getting in there, sitting down, getting in the place, but the stimulation is about 18 minutes. And a standard TMS course is once a day for 30 treatments in a row, generally followed by a taper where you do 3 treatments one week, then 2 the next week, then 1 the third week. And then with TMS, we generally stop. So unlike with ECT, where we encourage people to do taper and maintenance for 6 months after an intensive course, with TMS, the standard of care right now is actually to do the intensive course and stop and watch and wait. 6 out of 10 people respond. And of those 6, 3 of them approximately will still be well a year later with needing no TMS or in the meantime. So the relapse rate in that first year after an intensive TMS course is
50
around 50%. Yeah, and the data varies. I mean, it depends on which study you look at, and you can
Right.
cherry pick one that's really high or cherry pick one that's really low. The meta-analysis, meaning like sort of taking all the data and kind of trying to put it together, that was published a few years ago that I think did a really good job of this. It ended up being about half and half.
And so with TMS works well for someone, does that mean, I don't necessarily want to say cured, but is there still a need for medication in that 50% that's
It
staying?
depends. Yeah, it depends. So first of all, we don't recommend people make medication changes right before a TMS course because it gets messy. Then we don't know if a person gets better, what it was. And
Right.
you really want to know if TMS worked for you because you want to know if you should invest in it again. And even if your insurance is covering every penny of it, which usually is not, there's
It's a
some
lot of
copay.
time. If it's,
Yeah, it's a lot of
day.
time. Right? So you want to know if you need to put that time in again. So a clean trial of TMS would be really no medication changes right before, no medication changes during, trying to get the appointments at a similar time of day, because just like with ECT, where I actually didn't go through this, but at the first treatment, we figure out what your dose should be by doing a titration. With TMS, the first treatment you come in for, we also are figuring out what your dose should be. And what your dose should be depends on factors like how much you sleep, how much coffee you've had, what time of day it is. These usually are things that, and what medications you're on, that are like small changes. But you don't want to be at the wrong dose because it might not work as well. So TMS, by the way, is not done in a hospital. There's no anesthesiologist involved.
You're kind of just sitting there with the machine.
Exactly. In our office, we use dental chairs just because they're really flexible in positioning and pretty comfortable. But you can use any chair really. And with TMS, it can be done in an office building, right?
There's no downtime with that either, right? I mean, as in like,
there should be no cognitive side effects whatsoever. And there are even studies using this same protocol or really similar in people with early Alzheimer's or mild cognitive impairment that have shown some improvement in thinking and memory with this protocol. The data isn't strong enough for people to generally be offering this clinically in a lot of places, but the papers are really interesting. So if anything, it should be pro-cognitive. That said, there's always that, 1 in 200 people that have something unusual, but super, super rare. And then goes away immediately when we stop the TMS.
Right.
And so, yeah.
With all of this, it's really about also informed consent, like making sure the patient knows the risks and the benefits. And
we do not include anything about thinking and memory in our informed consent because in studies, it is not a thing, right? If anything, people get better with their thinking and memory, not worse. And there's no anesthesia. You're awake, you're sitting in an office in a chair for 18 minutes, right?
Obviously, there are side effects or potential, but in this case, there's a much lower.
So much low. I mean, not even comparable to ECT, right? But it's a different kind of person who's looking at this versus looking at ECT. It's severity level, it's urgency, it's preference, right? It's diagnosis too. So TMS right now is not covered by almost any insurance plans. It's not covered for bipolar depression. So people with bipolar disorder, very unfortunately, coming in for treatment have fewer options than people with unipolar depression who've never had a hypomania or a mania. TMS really does not, in a person, let's say you do use it for bipolar depression, it does not increase the risk of flipping to mania any more than anything else does. So that was a concern early on that just did not pan out with studies looking at that carefully. It also has very little in the way of side effects otherwise. So a headache is the main one. And that's because it feels like a tapping on your head. So a feeling of tapping on your head for 18 minutes is, at least at first, for a lot of people, not the most comfortable. Yeah. People get used to it really by treatment 3 or treatment 4 and then have no issue after that generally. It depends though. There are some people who have like chronic pain conditions where they're just kind of already primed for pain and it's a little bit less tolerable sometimes. Also, people with a history not history, not like remote history, but medical history, meaning things that have happened to you medically anytime before now, who have frequent migraines. I've had a few in the past 5 years that I've been doing this, who have stopped TMS because they got more frequent migraines during TMS. Ironically, though, there are other ways of using the same machine that prevent headaches, right? Just putting it on a different place and different protocol, right?
There's so many things in the medical world, right? Because it's practicing medicine, right? Like you don't know always exactly what is going to happen because we're all different and we're all.
Yes, and you have to keep up with the literature. You have to like read the articles that are coming out in order to know, am I still doing the right thing? And then you have to be critical of those articles because you don't want something to come out that was, no control group, 30 people,
right,
and then say, wow, now I need to change what I'm doing. That isn't enough. So a physician, a lot of our education is understanding how do we know what we know? How do we learn what we learn? And how do we look at this in a critical way in order to know what to do with this evidence and when? That is, I think, the key of why physicians are in school for so long, and a difference between different numbers of years of training for different professions. That's something that physicians have in a way that is really hard to get with a shorter education.
And I think it's important to understand, like you're a psychiatrist, but you need to understand how, like, say, the renal functioning is of someone because, right, there are some medications that might impact the kidneys or.
Oh yeah. And this is something that I think is not well understood. So I appreciate you asking about it. But one of the most important things that I do is understand I'm not going to say all, ideally all, but most of the medical conditions that could look like something psychiatric or be contributing to psychiatric symptoms. Right. And try and make sure that what I'm looking at really is primarily psychiatric, or even if it is primarily psychiatric, whether there's something physical, not brain physical, but body physical that's contributing to it, where we can do something about that too. So lots of brain tumors look like psychiatric illnesses. Right. Meningitis can look like a psychiatric illness. Endocrine diseases, cancers can look like psychiatric illness. And if a person is trained only in mental illness and not in all of the other things that happen to the body or how everything else in the body works, then it's really easy to miss these things. And if you haven't done, rotations in hospitals in other fields of medicine, and you haven't seen any of this stuff, you haven't seen the neurological disorders, it's really hard to recognize something you've never seen. So that's why the education is so long. That's what it's all about. And so I frequently recommend people go to a sleep clinic because I catch, maybe they have sleep apnea or more rarely, but still sometimes narcolepsy. Or I think, wow, that sounds more like you might be having seizures. Let's make sure you get a EEG in order to evaluate that and get in with neurology for an opinion. Or, whoa, this is Parkinson's, right? This isn't schizophrenia. So there's a lot of that is my job to do.
Even like your thyroid not working correctly can look like depression, or because it makes you sluggish. Yeah.
I put together a couple of years ago with the Washington State Psychiatric Association, but I did the large chunk of here are medical diseases that can look psychiatric, and the list was really long, really long list.
But I would, before we and sleep is something that I am passionate about, and I don't just mean because I enjoy resting. I've noticed for me, when I have a relapse or when I feel like I'm coming close to a relapse, sleep is the thing that I'm often missing out on. And when I talk to people, I'm like, get sleep. This, like, I can make up sleep on the weekend, so I'm not going to get it during the week. Or, I've heard people, that I'll sleep when I die. Sleep, like, you're going to die sooner if you don't sleep. I believe that on some level.
Honestly, we could have done this entire interview about sleep and it would have been just as interesting, but sleep is really underestimated in terms of importance. You spend a third of your life sleeping for very good reason. And what sleep does and how and why we sleep, incredibly fascinating. Also not completely known. And this is a thing in expertise. The more you learn about something, the more you realize how much you don't know. People who know very little about a topic tend to think they know more about it than people who know a lot about the topic and think, oh, actually there's so much more I don't, right?
The iceberg, right? It's
exactly, you don't see what's under the water. So with sleep, there is a complexity to what your brain is doing. And I referred casually earlier to anesthesia as sleep. It's really not even close, not the same. What's happening in sleep is you're progressing through these different states of brain and body called sleep stages. And each sleep stage is different in terms of what your brain waves are doing, how much sugar your brain is using, so metabolism, how much your body is moving or not, heart rate, blood pressure, all of these things are varying in sleep. And we think at this point that there is good reason why we have different sleep stages and why we progress through them in a certain order, because these different sleep stages have different functions, different things that they do for us. So we know a lot of things that happen during sleep. It's harder research-wise to pin it down to when, although there's valiant efforts and really creative studies. We think that emotional processing, like taking memories and deciding, is this emotionally, important enough to me to remember, or do I get rid of this memory? Taking traumatic memories and dampening down the emotion associated with that and making it essentially fade appropriately over time. These are all things that we know happen during sleep. One of my favorite studies is when a person remembers, in this study, a person would remember a list of words before falling asleep. And an example would be sill, curtains, blinds, glass, view. So you hear those words and
you dream about windows then?
Well, not exactly. You think they're all maybe, but you think they're all related to window, but the word window isn't on there. And before you go to sleep, because you're memorizing this list, you actually should know that window isn't on there. It wasn't one of the words you memorized. Maybe you don't think about it, but it's not there. And then the next day, when you're getting retested on that list, window is in there. You remember the word window, because what your brain is doing is taking information and putting it together and creating insights or new ideas, or putting things in a way that makes more sense to remember them going forward. So it's much more efficient and helpful for your brain to remember the theme or the word window than to remember all of these different little words, right?
And sleep.
So the idea for the periodic table came to the creator of the periodic table in a dream. That's a very fun example.
And I think, for me, I know that I need at the very minimum 7.5 hours of sleep. I don't know why it's that. I think it's right. It's a 90-minute sort of cycle in general, or does it, and it changes, right? As you get more into the sleep, like deeper, or the more cycles go through. I'm not sure I'm getting it.
I think I get where you're going. I do. So in the early part of the night, what a sleep cycle looks like is different than what it looks like later in the night. So you actually have going more time down into deeper stages of sleep early in the night, those first 2 cycles, and then the next 2 cycles, it's shallower. And that leads to this phenomenon sometimes of people who are depressed and sleeping really long hours and sleeping well into the morning, and they get more and more dreaming as they go along, because dreaming is one of the sort of shallower stages. So with sleep, I also just want to mention immune function is really impacted by sleep. There's these really good studies on giving somebody a vaccine and then testing how well this vaccine took in their system after sleep deprivation versus appropriate amount of sleep. And there's a big difference. So if you ever get a vaccine, please sleep well the night after.
I mean, I think, right, I've heard, and in my experience too, like weight loss is impacted by your sleep.
Hugely. Appetite, metabolism. Yes.
All of those things. And I think we also need to remember that, correct me if I'm wrong, but our brains use the vast majority, like use the majority of the calories that we consume in a day, unless you're super physically active, right? But if you're just sitting still doing nothing, your brain is going to be using the majority of your
yeah. I mean, I think that the importance of sleep and how interesting sleep is just really underestimated. I think it's because people don't remember sleep. It doesn't feel when they've woken up like they've done anything useful.
Yeah.
Really have. It's important.
And I think along with that, it's, well, I'm not doing anything, like I'm missing out on something perhaps, because you're not awake for it, you're not experiencing that thing, but it means you're not going to experience other things as richly, perhaps, as if you have that.
The impact on mood, the impact on remembering things. I mean, yes, 100%. The impact on your ability to regulate your emotions, right? It goes to mood, but even in people who don't have mood disorders, that's a thing. So and cognition, and there's been great studies in physicians and doctors in training on sleep deprivation and how well we do with speed-based thinking cognitive tasks after this much sleep deprivation and this much and this much. And the results are pretty shocking, because insight into your loss of ability is poor. You think you're still doing as well, but you're not. So people who are chronically sleep deprived may think, well, this isn't an issue, I'm doing fine, but they're not actually. So that's insight, recognizing when there's a problem, right?
So sleep, I am a firm believer that sleep, nutrition, and water or hydration are like one of the most, or maybe the 3 most important things for your health. Like that's a really solid place to start. Enough sleep, enough hydration, and solid nutrition to nourish yourself.
I think that's a great start. I think there are lots of people who would debate what are like the 3 most important things, but I would tend to agree with you. Sleep, hydration, nutrition. You
can't go wrong doing those things well, like that. None of those are going to harm you in any way. So thank you so much for all of this information. And it's a lot, I'm sure, for people to take in. And then along with that, I would encourage people to go check out like what these treatments really look like in real life. Do some Googling, and I'm not always a fan of Googling for all the things, but I actually found some really great information on what this looks like now.
National Institutes of Health, Brown, Mayo Clinic, Clinical TMS Society, International Society of ECT and Neurostimulation. I mean, there are reliable, good websites with information.
Well,
my own website, which is my practice's website, seattlentc.com. We also have information. So there are reliable sources. What I would be very wary of is message boards, or anything that's like, patient group advocacy,
right?
About X. The name of the group might not say against X, but there's a lot of that out there, and a lot of them are Scientology backed. So I think that it's really important to seek expertise, because that's what we're here for. I mean, that's what doctors do, is we educate people about what's out there, the pros and cons. I try hard not to tell people what to do, right? That's not our decision. That's not,
you want them to make that decision based on their needs and what will work best for them, or they've thought.
Right. It's if anything, a joint decision, but I say more, it's a patient decision. We provide information so that you can decide what is best for you. So I know some people sometimes, including my own parents, sadly, who say they don't want to go to a doctor because all he's going to do is offer me X, or all that she's going to do is say Y. Don't assume, right? You don't know what you don't know. And if a doctor says something you don't like, you don't have to do it, right? It's
just questions. That's what you're like. If you're uncertain, ask questions.
Exactly.
So yeah. I'm gonna get like links to these, the National Institute of Health, Brown, Mayo Clinic, all of those, and include them in the show notes so that you can go find really solid science-based information, because that is what is important, right? Sticking to science and research. So Dr. Allen, thank you so much for all the information. And I learned a lot, and I hope that my listeners did as well. So thanks again for that.
Thank you for having me, Amanda.
And then with that, we've reached the end of the episode. Thank you for listening and learning about mental health and society. Now go out and open a conversation and discover how mental health is experienced in your world. You can find more episodes of the Mental Society, all the places you can find your favorite podcast. And don't forget to subscribe. And remember that you are not alone in your struggles, that hope and help are all around you. And until next time, wishing you good health, mental and otherwise. This is Amanda Dolan.